on. And I just want to invite Rahel Musyoki, who's the CEO of Yunik Global and our convener today. She's a dynamic strategist, an ecosystem builder, and the founder of Yunik Global. She's a strong background in healthcare systems, investment readiness, and digital transformation. So she's worked with hospitals, with startups, with development partners to scale sustainable solutions. And her mission is to unlock impact and innovation where it is needed most. So Rahel, I'd like to welcome you so you can tell us more about the Healthcare Transformation Initiative. Why are we here today and what are we looking forward to?
Thank you, Jean. Thank you for that powerful remark and for moderating this session. And before I start, or before I share what this initiative is all about, first of all, good morning, everyone, and thank you for joining. We really appreciate you taking your time this morning just to sit in and have this conversation or listening to this conversation. So before, as I said, before I share the initiative and what the initiative is all about, I want to start with a very simple question. And you can put this on the chat as we continue because I know we have just a short time. And the question is, what does transformation really mean, right? What does it mean to you? And obviously transformation in this sector. And as you share that on the chat, let me just share my perspective in a few minutes. So for me, transformation is not, a flashy new thing, because when we think of transformation, we always think about what's this new thing that's coming up. So for me, that's not it. For me, it is step by step, right? Transformation is step by step. For me, transformation is rethinking how we deliver care, because we're talking about the healthcare sector. So how are we delivering care? How are we running our facilities? And the most important question is, how are we staying sustainable in this market? And Jean, you've talked about SHIF, and I mean, this is the elephant in the room. So how do we stay sustainable with the current times? And for me, sustainability as part of transformation obviously starts with, the small practical changes that build over time, right? And I mean, right now, I know there's a lot of financial pressure within the system, and everyone just wants that money to flow, right? But transformation has to start from somewhere, and it has to start small, and those changes have to be very practical. And because the system is right now under pressure, there are things that we need to start thinking critically about, right? Because, I mean, SHA and SHIF was supposed to bring stability, right, to a lot of providers. But I read from one of the national associations that supports hospitals that about 90% of providers are in financial distress. And I was thinking 90%, this is the whole entire healthcare system. So definitely there's something that needs to change, and it needs to change drastically. And a lot of hospitals, and this is just from the information that I know, is a lot of hospitals depend on SHA and SHIF and the national insurance model. And I mean, when I hear about that, it just makes it even more sad, right? And because this is the only hope for a lot of these providers, and I mean, a lot has to change. And then on the other side, right, digital health, that has been a buzzword for some time. The digital health has been positioned as the answer, as the silver bullet to answer all these challenges, or to be the solution to all these challenges, including the financial distress that a lot of these healthcare organizations are going through. So you have all these applications coming up, you have donors coming, promising all these things, you have pilot projects. But if you're really honest, and if I can ask everyone here who represents a hospital or a healthcare organization, to be honest for just a minute and say whether this has actually moved the needle for them. I know um, we will hear different comments from the ones who are represented here. So that's the reason for the Healthcare Transformation Initiative, and that's why we are launching it today. And this is just a precursor to all the amazing initiatives that we will be putting together. And this is not another report, right? When people hear a transformation initiative, they think about, this report that will come out of it. But this is not just a report. And it's also not a donor-driven agenda or a political agenda. It is a practical and action-oriented movement. And we want this initiative to be led by the healthcare providers that are represented here today and others who might not be able to join. So this is an initiative or a movement that will be led by the healthcare providers, and healthcare providers cut across the divide, right? We have the hospitals, the clinics, the pharmacies, the insurance companies, and so on and so forth. So a movement led by the providers for the healthcare providers. And because one of the things that we need to do, or one of the mindset shifts that needs to start happening, is waiting to be told what to do. Because when our systems get to this level, these extreme levels, we normally sit back and wait to be told what to do. But I believe we need to start designing our own solutions, and solutions that work for the reality that is on the ground. You know, you're told when you go to the ground, things are different. So we need to start designing solutions that work for what is on the ground, for the realities that is on the ground. So let's be the ones to start this transformation. As I said, it's a step-by-step approach, and it starts with those small shifts, one by one. Digitizing records, streamlining inventory, improving quality, introducing digital systems that work for good, not just for operational efficiency, but also for the quality of care for the patient. And from there, we definitely build, better systems, better data, stronger operations. We make smarter decisions. And then from there, we have all these new products. We start diversifying income so that we don't just rely on the traditional model or this one model that probably worked before and is not working right now, right? And then we have investment readiness introduced into all this structure. And from all this, I believe we can scale. So this is not about leaping. We are saying, so let's take these first steps together. And for me, and what I believe is transformation starts from leadership, from the leaders. Like in any house, the leader is the one to set things in motion. And that's why we invited you for this session today. And apart from leadership, obviously, there's also an element of understanding and how things need to work. And we need to ask the questions on whether digital health is the answer to the transformation that we really need, or we also need to change or shift policies. And remember, digital health is not just about telemedicine. It's about systems, right? Digital systems or innovations that help reduce manual processes by, 80% or more, or the solutions that allow you to monitor patients remotely so that you can start earning new income from a new product. And obviously support you to stay afloat when we have the payment delays from SHA, right? And the real question is not how much it costs, but how much it will cost if we do not adopt. And we are seeing the cost right now, and the cost is the financial distress that is in the system at the moment. Because transformation is also not just about money, it's about quality. And quality is no longer optional, right? And with the upcoming quality of care bill, we believe that providers will start being held to higher standards. So transformation for us means all these things encompassed into one. And that's why we are calling it the Healthcare Transformation Initiative. So this initiative, in summary, will help you or will enhance your understanding of the power of innovation. That's number one. And number two, it will support in improving quality and efficiency within the environments that you are in as healthcare practitioners. And then number three, it will support with diversifying income and killing the overdependency. And then lastly, it will support with becoming investment ready, because majority of the healthcare providers are looking for investment. And investment is not necessarily the money part, it's also partnerships. So to conclude this remark, what I will share is one of the things that we understand with this initiative is, as we bring you in, we need to understand you better. We need to understand the full picture, because sometimes we don't, as the outsiders, we don't necessarily understand the full picture, but we want to start the process by understanding the full picture. We need to understand more about your needs. And that's why I really appreciate the partners who have come on board to support us with this initiative. Population Services Kenya, Kenya Association of Private Hospitals, the Digital Health Committee by KHF. Thank you so much for supporting us with the start of this journey, because we know with this we will co-create what works for the system. And I hope we will see that transformation over time, because I believe it's high time we moved from survival to transformation. So there's a link that is going to be shared on the chat, and please take your time to indulge us on it. And this will help us start this journey, because as I mentioned, we want to understand more about your needs. We want to understand what else do we need to start thinking about to just change the shift of what the healthcare system needs at this moment in time. Thank you so much, and back to you, Jean.
Fantastic. Thank you so much for that, Rahel. I think really clear points there. We're rethinking how we deliver care. It's action-oriented movement, right? Because we've been discussing long enough, and now we need to move to the doing part. And this is something that is for healthcare providers, by healthcare providers. I really love that. And quality is no longer optional. And I think that one of the last things you said there that really stuck, we're going from survival to transformation. And thanks, Alan, for your contribution. I see that you put in the chat that to you, transformation means a marked change. And that's really what we're looking for. It's a sustainability aspect. And so I'm really excited to introduce to you our keynote speaker for today, Dr. Eric Musau. He is the chairperson of the Kenya Association of Private Hospitals, and he's a leading voice in advancing quality. We'll see that quality is an overarching theme here today. Accessible healthcare in Kenya, and with a strong background in health systems leadership and clinical practice, he has been instrumental in shaping policy dialogue around private sector engagement, healthcare financing, and New HC. He's passionate about digital innovation, public-private collaboration, and strengthening healthcare delivery models to better serve communities across the region. Karibu sana, Dr. Musau.
All right, thank you. I hope I'm audible.
Yes, you are.
All right, thank you. Thank you so much for the introduction. And thank you so much to the Yunik Global team for just a brief overview of the reason why we are convening today. And I would just like to add on what you have talked about, that indeed we are in very interesting times. Times when the sustainability and the survival of healthcare facilities, especially in the private space, are quite, the sustainability is questionable. And I think one of the things that I wanted to discuss today is to just, give an overview of the current state of hospital operations in the face of reimbursement delays. And to give context to this, I think I want to start with the genesis of this particular problem so that we understand how we ended up where we are, and probably think of ways and means of ensuring that the next couple of months, years, be dedicated towards meaningful solutions to addressing the challenges that are there and making the social health insurance work for each and everyone. So with that said, the issues of delays did not start with SHIF. They started with NHIF. And the early signs of distress were noted in 2022. This was just immediately after the 2022 general elections. And prior to that, we had what we normally call the golden era in healthcare. I think that's when the payments were on time. Everybody in the healthcare space was doing well. There was a lot of growth, innovation, more and more services being incorporated by providers. Access to credit back then was not a problem because liquidity again was not an issue. So that period from around 2013, 2014, thereabout to 2022, mid-2022 was what I may call the golden era of healthcare as far as NHIF was concerned. So, and as I mentioned, the early signs of distress were just immediately after the general election, and this was expected, given the fact that whenever you have a transition from one government to the other, from one financial year to the next financial year, because we were around that time, we tend to have delays in reimbursements, which are normal. But that particular year, we had these delays extending significantly all the way to December. And I think the full-blown delays were experienced in 2023. And again, towards the end of 2023, we had sweeping changes as far as the healthcare dispensation is concerned. And that's where we got a glimpse of what the Social Health Authority would come. I think that's when the gazetting was done. In around, that was 22nd of November 2023. And that was listed as the official commencement date of SHA. And the act came with a lot of changes in terms of the management of the existing schemes within SHA. And there was a transition clause that was to provide a one-year transition period from NHIF to SHA. And I think that was the second thing that compounded the problem, because this transition was a bit rushed. We did not look at the implication it would have in terms of payments to providers. And then again, come December 31st, as per the SHA Act, then the NHIF then was supposed to stop onboarding all what we used to call managed schemes. And essentially what this did was it decapitalized the fund while at the same time continuing to pay for medical liabilities. And that just made the problem worse. So we cut down the source of funding, but the outflows in terms of settlement of claims did not change. So retrospectively, that would have been the time probably the government should have introduced the 2.75% to at least bridging the cash flow deficit that the fund experienced thereafter. But that particular period saw bulk of the strain being leveled, most of the strain, being experienced by both public and non-public facilities. And by non-public facilities, I mean both faith-based institutions and private hospitals. And what we had during that time in terms of payments were very minuscule payments. The collections also dipped because there's something they call the insurance death spiral. When an insurance company is unable to meet its obligations, and the people who are paying are unable to get the services as a result of that, then they're not incentivized to continue paying. And this cycle basically worsens the situation, because when they stop paying, the fund slowly sinks deeper into financial distress as well. So as at 30th of September 2024, the total liabilities the fund owed to private hospitals was around 30 billion. This is actually all hospitals, was around 30 billion. The last disbursement towards these payments was done in October, and since then, no payment has ever been done in relation to the old NHIF debt. So in 2024, that was last year, October 1st, we had the rollout of the Social Health Authority, and it came with its attendant challenges, an incomplete system that was being developed on the go. And again, we had an incomplete module because the system could only manage patient registration and service provision, but the back-end accounting modules reconciliations were not yet fully resolved. Some of them have never been resolved to date, and they are part of the reason why we are having these particular reimbursement problems. So payments have been forthcoming since then. However, they have not been coming in tandem with the amount of claims that are being generated. And as it currently stands, SHA has only managed to settle on average 40 to 45% of the total claims raised by private facilities from 1st of October to date. So if the trend continues, this means that by the time we close this government financial year, more than 60% of the providers' bills will be outstanding. And it will be a very interesting financial position for SHA, because it raises a lot of questions in terms of, is it that the money is there and there are other technical issues that are affecting payments, or is it that the money is not there and probably this is what they can only manage to pay? So that's the conundrum we're in. And the surveys have basically mirrored what I've just mentioned. If you look at most facilities, they are in financial distress. We have credit crunch affecting most providers. And as a result, we have stockouts from hospitals, we have layoffs, banks are calling because most providers are unable to settle their bank obligations. Most have been forced as well to scale down operations, and some of the capital intensive services like oncology and dialysis have had to wait for some providers. Currently, surgical claims are not being paid timely, some dating as far back as last year, and I think that's where bulk of the problem is. Surgical claims are quite heavy because they carry professional fees for external doctors. They also carry consumable costs and implant costs, especially for orthopedic procedures where the cost of implants could go northwards of 100,000. So this creates a very tough operating environment for providers. On the same note, we are also having difficulties as well raising capital, both in terms of debt and equity, because the industry is not liquid. No investor is looking towards putting money in a very volatile market where cash flow uncertainties are the norm. So raising debt, raising equity becomes quite expensive if available, but most often than not, the opportunities are limited and spread far in between. So we've also seen closure of hospitals as well. And looking forward, the situation doesn't seem to improve because, one, we have not seen inclusion of old NHIF arrears in the 2025-2026 budget. We have combed through that document. There is no single line item on NHIF arrears. We've also seen a significant underfunding in PHC and the ECCIF fund. 13.1 billion has been allocated to primary healthcare for the next financial year. And with 22 million Kenyans registered, actually, the latest data from what the Cabinet Secretary shared was 24 million. This means that we are working with just slightly under 590 shillings per head versus the 900 shillings that was promised. So that tells you that even the PHC fund is going to experience a lot of constraint. And it kind of puts the government in a very, I mean, the situation in a very interesting position, because how do you push for more registration of Kenyans when the budget allocation is not commensurate to the numbers that you envision? And this means that it is the providers who are going to underwrite these costs. So we will see more and more of delayed reimbursement in the next financial year if the situation remains unchanged. So putting all these things into context, then as private providers, one of the things that we've been asking ourselves is, how then do we operate in the midst of such difficulties? Because we have a lot of external factors. The cost of care is not dropping, it's going upwards. Cash flow problems, challenges in getting investments, and even the future looks a bit dim in terms of what we can already see. So what does that mean for providers in the healthcare space, and not just hospitals alone, because hospitals are part of a larger ecosystem. We have suppliers for drug manufacturers, for medical consumables, for equipment. We also have our bankers. What does that mean? Are we looking at more and more defaults in the next coming months? Should we start rethinking about restructuring of our debts? How can capital be availed that's affordable to facilities to enable them operate? Finally, I think one of the good things is that SHA has been publishing their payment data. And it's one of the first steps towards transparency. And we do hope that it's not just what the providers are paid that will be published, but it will be good for us to know then how much are they collecting, how much are they paying out as claims, and consequently, what is the financial health of the fund? Because if the financial health of the fund is at risk, then we will end up with another situation that is probably worse than where we are. Then again, still looking at the sustainability issues, we are also getting into a situation where the old NHIF liabilities, actually the current SHA liabilities have actually matched the old NHIF liabilities. So how then do you provide care with two sets of bills that are uncertain as far as payments are concerned? So there's a lot to ponder on. There's a lot to look at from a private sector point of view, but for the policymakers, there's a lot to also look at in terms of the sustainability of the fund, the contribution mechanism, formal sector versus informal sector. How then do we build trust? Because we have a trust deficit between the public and the fund. How do we build that trust so that the fund can be able to benefit Kenyans and can be here for many more years? So that's just a brief overview of where we are as a private sector. And I think such opportunities like what we have right now are basically one of the ways of trying to answer the question, how do we operate? Are there ways that we can leverage on digital innovation and collaboration in navigating this role of quality of care. How do we handle or how do we maintain care when we are grossly underfunded? One of the things I like that the current CEO of KHF, Dr. Tim, mentioned is that the quality of care drops immediately whenever funds are not availed. Because the moment you have no money to buy even basic drugs like, painkillers, antibiotics, there is no innovation around that. So how then do we ensure that we retain or maintain, if not improve, the quality of care, especially with the quality of care bill around the corner with very hefty fines for those who have gone through it. So that's just an overview, and I'm hoping that these conversations here will bring in new ideas and new insights that we can be able to use and see how then we can navigate this particular situation together. Thank you.
Thank you so much, Dr. Eric, really taking us through the journey of where we started and highlighting the fact that we need meaningful solutions. I mean, it's quite alarming when, we're talking about more than 50% of providers will have bills outstanding. And so how do we continue to be sustainable? How do we continue to provide service? How do we do that and offer quality care in the midst of everything that's going on? I'll pause here and just see if any of the participants have any questions for Dr. Eric. I can see some comments there. Yes, Nyakeo, the bill has been a little bit contentious. So we have been adding our remarks during the public participation. That is important work that we must do as health sector leaders. And I see Robert has added one here to say that the role played by private sector in provision of health services in Kenya, despite challenges faced. Absolutely. We saw that 5 years ago, just how the private sector really came in during COVID, and the contribution cannot be overstated. So if you do have any questions, please feel free to raise your hand or just pop them into the chat. Okay. In the absence of questions, we'll still get an opportunity to ask Dr. Eric questions in the panel that's coming up shortly after this. Rahel did mention that we cannot do this without partnerships, right? The shift doesn't happen in a vacuum. You need collaborators. And PSK is one of these partners. And I want to introduce Sylvia. She's a director of private engagement at PSK. She's passionate about health system strengthening and social impact across the continent. She has a background in public health and program management, and she's led and supported initiatives focused on community health, on digital innovation, and equity-driven service delivery. Sylvia is committed to advancing inclusive solutions that improve lives and build resilient systems across the region. So Sylvia, I welcome you to give your remarks. Karibu sana.
Thank you very much, Jean. Indeed, it's a very exciting session, very inspiring. The first two speakers were point on, and I know as private sector providers, we can say that it's a time for change. So as Jane and Rahel have said, PS Kenya is collaborating with Yunik Global, and we're very excited because it's different. We've walked a long journey with healthcare providers, I think from a long time ago. And someone has just said that we have to start thinking differently. That was then, when we were providing a lot of support, which was donor funded. Today, the narrative is different. We just know that the US government is no longer funding governments. If it's not funding governments, the private sector is also affected. And therefore, this initiative is different. We are talking about healthcare providers by healthcare providers. So it is a journey that we are going to work together with the partners, Yunik Global, many other partners, PS Kenya, to see that we are addressing all those things that have been mentioned here. We know that it is very clear today that it is no longer about, waiting for people to come and tell us what to do. And a lot of discussions that we have had here have mentioned sustainability. Indeed, sometimes you have to be pushed to the wall to start thinking differently. We've talked about SHA. What about if we are to start innovating other products like microinsurances? We can work with the government, we can work with the private insurance companies and come up with good products because we are known for being innovative as private sectors. By the way, when the public sector looks at us, they see innovators. So what about establishing very strategic public-private collaborations? And we look at ourselves as the people who are showing the public sector the gaps, and of course, identifying our role and critically and very strategically positioning ourselves for changing the health system today. So sustainability must be front and center to everything that we do. And as PS Kenya being a local NGO, we have learned that. And we know that the private sector actually is key and very critical in seeing that the health system is sustainable. The other thing is about innovation. It is no longer a luxury, by the way. We have to put it at the center of everything that we do. And just as much as we're talking about having so many challenges that are affecting the health system today, that does not stop us from thinking differently. And I think this initiative that is being led by Yunik Global is very critical in helping us just identify those things that we must do, because we have great minds, we have talent, and we know the health system, and we know what can work in Kenya, what can work in Africa, what can work in the region. We really don't have to think just within our borders. We need to think broader than Kenya. So this initiative is very critical, and I know we've worked very, very closely with the private healthcare providers. So my urge is that let us support this initiative and be part of it. Let's actually be willing to invest. We know that there's nothing we can do without investing. We need to invest time. We need to invest resources. We need actually to invest even in thinking. We need to be think tanks and work together and see what do we need to do to change the narrative that we have today. The other thing is utilization of digital. I was very excited when Rahel said that digital is just not telemedicine. We can use digital to actually enhance our reach. We can use digital to do things differently, even at healthcare, within our health facilities. We can use digital to establish those public-private collaborations. We can use digital to actually keep enhancing our skills. So it is a lot. It is about just thinking the whole ecosystem. And finally, we must just have a totally different mindset. We must shift our mindset and just look at ourselves as being the center, being the innovators, being the people who are driving sustainability, and not waiting for the government to sort out things for us. We know that we are reaching about 50% of the population in Kenya in terms of provision of healthcare. Then the market is there. And actually, we can even do much more than that because we have the capacity. So let's work together and let us embrace this initiative and see how we can do things differently. Tomorrow, for yesterday, we have learned lessons, and let's keep, putting them in the innovation. But it is extremely important for us to keep thinking about how do things look like today? How can we do things differently? What lessons have we learned? And not to be in the situation where we are as Kenya today. We are seeing there's not enough funding for the health system. And by the way, that is an opportunity for us as private healthcare providers. That's a great opportunity. How can we start looking at the challenges that we have as Kenya that are driven by the public health sector and now take over? Because at the end of the day, that is the only way we'll get there. So I'm very excited to be here today. Thank you very much, Yunik Global. I know KHF is here, one of us, and the other private sector players. We know will be the game changers in this health ecosystem, and therefore I'm just watching the space, and I'm very excited to see all of you here. Let us keep going. Thank you.
Thank you so much, Sylvia. Indeed, amidst chaos and crisis, there are still opportunities for us to rise up, particularly as private sector, and innovate. This takes us nicely into our next segment, which is our panel discussion, which I'll be co-moderating with Rahel, and I'm absolutely delighted to introduce our panelists today. So I'll start off with Gideon Chalo. Gideon is passionate about Africa, and he's dedicated the past decade to leveraging his tech expertise to bridge healthcare gaps on the continent. He co-founded iDaktari and Unimed, both focused on providing affordable, modern digital healthcare solutions. Unimed is a cloud-based, highly configurable platform that manages clinical and financial hospital operations, offering significant scalability and efficiency. Gideon leads Unimed's Africa operations from Nairobi, overseeing activities across 6 African countries and maintaining business relationships in West and Southern Africa. And since 2020, he's negotiated SaaS, software as a service contract valued at $1.1 million USD. And his long-term vision is to transition into venture capital, primarily investing in African startups and mentoring entrepreneurs to foster innovation and economic growth across the continent. Karibu sana, Gideon. Geoffrey is the Group IT Manager at Avenue Healthcare, and he's the CIO of the year 2024. A huge congratulations to you, Geoffrey. He's an experienced IT professional with a strong background in healthcare technology. As Group IT Manager at Avenue Healthcare, he has led key digital transformation efforts focused on improving service delivery and operational efficiency. He's committed to innovation, efficiency, and leveraging technology to drive impactful community solutions. Next, we have Robert Nero, who is a reproductive health, quality assurance, and health system strengthening expert with over 15 years of experience. He currently serves as the Regional Programs Coordinator at PSK, supporting the Accelerate program in Nairobi and Kajiado. He has led successful donor-funded programs such as USAID, UKAID, Global Fund, and more, and previously worked with Mary Stopes Kenya and TICO Africa. His work is grounded in a strong commitment to ensuring women and girls access quality reproductive health services. And Dr. Eric will also be joining us in the panel. So as we're just thinking through reframing the problem, thinking through the big picture, we often talk about fixing the system, what do we need to do to change things? But if we could just reimagine, and that's what we're doing here today. I'll start with you, Dr. Eric, following on from your keynote speech. If you had to rebuild Kenya's health system from scratch with only 50% of the resources, we've talked huge numbers in the billions, but if you had just 50% of those resources and full access to digital tools right from the start and access to the talent required to deploy those tools and use those tools, what would you do differently?
All right. I think that's a very interesting question. It takes a lot to just look into what you believe and what you philosophize as your ideal healthcare system. But that said, for me, I have always opined that we have a fragmented system in such a way that it's very difficult for you to know where you're headed to, where you're coming from and where you're headed to. And one of the examples I like giving is the amount, the contributions. If you look at the Social Health Authority Act, the contributions were gazetted before even the benefits were known. So we were basically paying, or rather were contributing before we even knew what we were paying for. And that just tells you that it's money first and services later. So, but I would, if I had the opportunity, I would change that to services first and money later. And what do I mean? There are just 3 questions which we'll need to answer, which I've always said in every meeting regarding what would be the quality of care, or rather the kind of care that Kenya needs. And the first question is, what kind of care does Kenya need? Or what care do we envision for our country? So when we say, we are providing high quality maternal care, what does that mean? When we're saying we're providing high quality antenatal care, what does that mean? Is it a patient who has been attended to by a gynecologist? Is it a patient who has been attended to by a nurse? Is it a patient who has, gotten brand X or brand Y of drugs? What does that mean? That has never been defined. And I was expecting to see more of that on the quality of care bill, but we just probably focused more on finance and compliances and many other conversations. So once you answer the first question, the second question comes in is, what is the cost of this care? So if we determine this is our standard of care, that every mother going for antenatal care is to be seen, first clinic, say by a consultant gynecologist, the second clinic could be a medical officer or whatever it is. Let's cost that. Then once we've costed that, the third question that we ask ourselves is, how do we finance that kind of care? Even if it's going to cost us 1 trillion shillings, but at least we have some kind of vision of where we are headed. So then while at it, then we can ask ourselves, how much resources do we have now? And how do we slowly bridge the gap to the required budget? so that we are working towards a purpose. And I think if this is a conversation that had been adopted with SHA, probably even Kenyans would have told you the 2.75 is little, then let's talk about 5 or 10%, as long as they know there's an end point where basically they will not be paying anything from their pocket. So it is basically re-engineering the thinking. Then from there, we can sit down and work and build resources. I always say raising money is the easiest part, but it's difficult getting the winning formula. Thank you.
Thank you so much. I love that. We were asking for money first and then defining services later. So when you think about it, then what does that tell us about what we're over-investing in, or what are we underutilizing? Because if raising money is not necessarily the challenge, and we know that in Kenya we have pilotitis galore, we've had so many proof of concepts, so many pilots, we got so used to receiving all this donor funding. So what have we been putting too much money in, and what do we need to do to start shifting that?
So I think we've been wasting a lot of resources with a fragmented healthcare system. And, we can already see with the duplication that was there. We had NHIF national scheme. We had a parallel scheme called Linda Mama, then which again, the coverage was interesting because it only covered 4 antenatal visits. Why 4? I don't know. The Ministry of Health advocates for 8. So there was a misalignment between MOH and what Linda Mama was providing. Then pays for the delivery. I think it was paying 5,000 or 10,000 for normal delivery and 17,000 for cesarean section. Again, how did they end up with the 17,000? Nobody knows. Who is supposed to do the cesarean section? Again, nobody knows. Then we were running another parallel scheme called Eduafia, where we were insuring a population that is already insured. So we were insuring school children who are already beneficiaries of their parents' insurance. And for those whose parents did not have medical cover, it meant that we were only insuring the kids, but we were not insuring the parents, again, which was discriminatory. So, and we were pumping in, I think, 4 billion shillings annually, together with on addition to another 4 billion for Linda Mama, that's around 8 billion. We're also running a health subsidy insurance program on the side, which had its own budget. We're running a civil servant scheme. We're running a national scheme on this side, which was contributory. So we had a lot of overlap, duplication, and of schemes. And it's a good thing that SHA has tried to address most of this, but it's not at the background of an established blueprint that we can say we are now at step 1 heading to step 10, which is our end goal. And this is the modality of getting from step 1 to step 2, step 2 to step 3, and so on and so forth. So when you have duplication of funds in healthcare, you just have a lot of money being thrown, but the problem is not being addressed. Again, we had the conditional grants that were going to level 5 facilities, around 250 million. I think that's the money most level 5 facilities get as conditional grant from the national government. We still were running Harambe's. We still had monies that were going to KNH, around 13 billion or thereabouts. MTRH, that's level 6 facilities. So when you have fragmented financing, you throw money at the problems rather than understanding the problem and curating a system that is efficient. Whatever we have, the 100 or so billion shillings, I mean, we pay 100 billion we give the ministry a budget of approximately 100 billion. This was even before they were running the ECCIF and the PHC. Just to run a few programs, yet counties that were running bulk of the healthcare in counties were not even receiving that amount. So it's a very convoluted way of financing that needs to be rethought, and harmonizing all the monies that are going into healthcare towards a singular pipeline that now directs funds to the respective programs and projects that are aligned with a certain goal or a certain vision that has been set. So I think that explains the current confusion.
Thank you, Dr. Eric. And just taking over from Jean, and to add to what you've just shared, I think there's also an underutilization of data, because where are all these models coming from, right? Most of them are reactive rather than data-driven. And I think that's a very huge conversation that we need to have around how we can utilize data more rather than reactive care. And I think that's what the system is all about, reactive care. What do you think?
Yes, I agree, because any decision that's not backed by data is basically guesswork. And, it shows in the outcomes. And this is quite surprising, because we were voted, I think, earlier this year as the second best country in Africa with the best healthcare system. But still, there's a lot to be done. As well, data and a plan also enables you to know what are the human resource gaps that you have, because they are anchored on an existing strategy. So if you've decided that quality, deliveries require you to have obstetrician for every, say, level 2 or whatever it is, level 3, level 4 facilities, then that means you know the current number of gynecologists you have, the deficit, and then you can put in resources towards training them. If it's also about the drugs, for example, the drugs we consume, we should be able to have an idea that this is our disease prevalence, these are our epidemiological reports, these are the drugs that we are consuming, significantly. These are the MOUs we need to enter with some of the manufacturers for these particular drugs, or even better, these are the drugs that we would like to incentivize local manufacturers to manufacture, because there's a guaranteed market that the country will buy from. So data is usually at the heart of everything. And I think as long as you don't have a harmonized system, it becomes difficult to collate all this material and make meaningful decisions out of it.
I agree 100%. And I mean, talking about data, when I was sharing earlier, I mentioned that there's this silver bullet that was introduced a while back, and it became a buzzword: digital health. And I mean, in East Africa, here actually in Kenya, we are leading in terms of innovation, but then there's a lack of digital adoption, or rather there's a lag, right? We don't have a lot of early adopters, and we still don't have a critical understanding of what digital health is all about. So to Gideon, why do you think this is, and what are the shifts that need to happen for the system? And when I talk about the system, I mean the whole healthcare system, to first of all understand, and secondly, to enhance the adoption of digital health for operational efficiency, to increase quality of care, and other benefits that innovation can actually do. And as you answer that, for everyone who has joined, thank you so much for joining. Please feel free to share your question on the chat. And if you'd also like, you can raise your hand and you can ask a direct question to the panelist. Over to you, Gideon.
No, thank you. Thank you, Rahel, and also to Jean, Robert, and Sylvia. Thank you very much. I think from the standpoint of coming from tech, because that's the voice I want to use today, is just important to acknowledge that Kenya has a really vibrant startup ecosystem. And I just remember my heydays. It's interesting that Dr. Eric was mentioning that in 2013 was the golden era for healthcare. It was also the golden era for tech. So between 2013 and 2019, I think if you had an idea, you couldn't lack $10,000 to raise it up, run a pilot. And for that, I think it's just important to acknowledge that it created such a vibrant tech ecosystem. And that's where there was a lot of innovation also around that particular period. However, I think I'll just use the experiences we've had and I've had as Unimed. When we talked to our first hospitals, I remember because of reading many reports, it could be the Oxford Business Review, it could be just looking and Googling what are the problems in healthcare. At a macro level, you'll hear a particular voice about, the doctor to patient ratio, electronic medical records, lack of reporting. But then the moment we actually entered a private hospital and talked to the management, it became very clear. Like they were saying, for me, the challenge, yes, it's medical records, but they also talked quite highly at the fact that they just would like to have something that helps them run the hospital. That's the first problem. And in a very quick period of time, I think we had to reshift our idea of innovation, and we put everything into a hierarchy. If we take what you normally call the hierarchy, Abraham Maslow's hierarchy of needs for human beings, we did one for hospitals, and sort of like at the base, there was the idea of just managing your cash and inventory, which are very big assets in a hospital. I'm sure the hospital owners here, for example, will acknowledge that. And then sort of like started putting other things on top of that on the second level. So the second level was just optimizing, reporting, measuring performance. And then at the very top, we have excellence. These are things like, if you're talking about innovation, you'll hear things like telemedicine, AI, remote access on mobile devices. Now, the challenge with innovation, and which now leads to the question Rahel asked, I think from an innovation standpoint, I think we've inverted that pyramid. And I feel like we like, when we talk of looking for that shiny new thing, telemedicine, AI, but then the question then becomes, are we really solving the problem at hand, or rather the core problem? Maybe AI has something to do and can close some gaps, but fundamentally, if a hospital is going through a financial constraint, like the RUFA report that we've seen, 82% of hospitals are actually straining, there's no way you'll talk about AI and someone is having a backlog of 6 months to 1 year of reimbursements yet sort of like lagging behind. So it's also just calibrating, and I think for ourselves as tech innovators and also for the ecosystem, I would probably summarize it in the idea of maybe just being humble enough to know that the problems tech resolves are not necessarily the ones that we normally come with. And for pilots, I think they're still an integral part of innovation and entire ecosystem. The only challenge, I think, is that we also have a lot of funding from outside that is maybe time-based. So if you have a pilot to run for 2 years, what happens after 2 years? And normally, if a facility, or if let's say a pilot has some, if you're talking about a county that wants maybe to have some good reports of what they're doing in healthcare and innovation, they would still take your pilot as long as you're paying for it. But then the question is it sustainable? We've gotten ourselves in situations where can you really create a model where, first of all, the counties or the institutions that are at hand can take up exactly what you're proposing after. So I think just being humble in that, and then also, for example, making sure that you build in sustainability from the start. If it's a public sector innovation, I think it's important to discuss what is the actual cost, get a commitment. It could be, I've seen really interesting models, institutions like, I won't say which ones, but I've seen institutions which have done this where it could be a nominal fee, 20% county invest, and then the pilot is financed 80% by the donor, just to get them in the modus of actually paying for something. And then eventually that can be staggered over a period of time. So yeah, to answer your question, in terms of adoption, I think we have definitely inverted those needs. And at the same time, I think we also need to move away from pilots that have a target of just, processing money from donors, and sort of like build actual businesses from willing buyers and willing sellers. So just echoing also what Dr. Eric said, let's just understand the problems first as well. Yeah, thank you, Rahel.
Thank you, Gideon. And I really love that. And just to piggyback on what you've said, and I believe this is part of the remarks that has been shared across, we need to start having the voices of the healthcare providers being heard, because For us, even as a consulting firm, advisory firm, most of the time we get information just from, a general point of view. And that's why this initiative is there, for us to have that intricate understanding of what is the actual need in the hospital. We know there's an element of financial distress and financial challenges, but then there are other issues. And I believe if we build this up over time, then we will see that transformation that we are looking for. And before I come to you, Robert, Geoffrey, you have the vantage point of being part of a healthcare facility, and you can talk more about that. And you have implemented innovation that has worked. I know this was not part of the questions, but just allow me to ask this because I know it is important for you to share just a snippet of what this has done for the system that you are a part of. And I mean, you won the CIO of the Year 2024 from the healthcare sector. I actually thought it would be from either the banking sector or financial sector, but it's from the healthcare sector. So there's something different that your institution actually did to implement innovation that works for them to address the challenges that are on the ground. So maybe share with us what that was, and maybe how you can encourage organizations, healthcare organizations, hospitals to start looking in deep at their challenges and using innovation for good.
Okay, good morning. So I'll just go and go ahead and introduce you to the two innovations that we had. The first one was the patient kiosk, which allows patients to basically self-register and initialize their visits with the hospital. So this simply just helps the patient fast track themselves. So instead of waiting in a queue, waiting for the reception to sort out whoever is sitting at the station to sort out the insurance, to sort out whatever is going on with their particular cover. If somebody has been here, especially if it's a cash patient, they can simply go to the kiosk, register themselves, pay whatever needs to be paid for the consultation, and then move on quickly to the triage. And what this has done is we have reduced the workloads at the reception area. So nowadays, the reception area, they're doing a lot of value work, which is basically helping people understand what their cover is about, helping them communicate with the insurance of what their visit is entitled to what kind of services they're entitled to have at our facilities, and to some level also help the patient understand what they need to negotiate or talk to about the insurance. And this gives, number one, our internal employees that good feeling that they have actually helped somebody, not just give me your card next and give me your money next. It actually helps them feel like today I've actually helped somebody, I've made an impact in somebody's life. So the other innovation is around our ICU. We have an automated ICU. So what this one does, it basically monitors the patient's life or stay at the ICU. And what this has done is take off the admin workload from the nurses. Instead of recording every detail that's going on with the patient, that's what the system does. So the nurse is left with a lot of patient contact time. The nurse is left with a lot of activities that are going towards patient care. And the other great thing that was that we discovered or we realized from the project was now handover time is less than an hour. So during shift changeover, there is an handover process where each nurse has to explain what goes on with the patient. But since half of this work is done by the system, so it perfectly records most of it. And the only thing that is being handed over is some clinical notes that need to be explained to in terms of what drugs have been given, what's the schedule, what did the doctor say. But the rest of the admin work has been done by the system. So these innovations follow very closely what our patients do and how they experience our services, and also follow closely for the ICU case what the staff do in terms of giving care. and what kind of work can we safely remove from them and have them have a lot of more patient contact time, improving our patient outcome in the ICU.
That's amazing. And I'm sure it has affected your bottom line, obviously in a positive way, right?
Yes, as you can imagine, everybody has a target to increase the number of services they offer per given time. And usually this is a linear graph when it comes to other resources. So with automation, you are able to say, with the current resources, I can expand to this level and maintain my quality. So that means instead of seeing, if you're seeing 10 patients, you can now see 20 patients without necessarily having to impact your resources. So yes, it does translate to a lot of cost saving in that manner.
Amazing, amazing. Thank you. Thank you for sharing that. And I mean, for Robert, you have a lot of interactions with these healthcare providers, and there's a lot, as we said, that needs to change, especially in terms of the mindset. So what is the urgent change that needs to start taking place, especially from a regulatory point of view and also from a cultural point of view, so that we can have this transformation across the sector?
Thank you so much, everyone. Rahel, Jean, Eric, Sylvia, Charles, Geoffrey, and the team, and also our participants who have joined in. First and foremost, before I even answer the question in regards to what needs to change in regards to the mindset, with one, we also need to recognize the importance of private sector players in health sector, and also to take cognizance of the fact that they actually contribute to 54% of the health facilities in Kenya, meaning almost more than half of the Kenyan population seek health services in the private sector first before they get to the public sector. So a 54% contribution of health facilities, all private, is a key thing. The other thing is the private sector also plays the aspect of expanded access to health by providing a lot of services in regards to health services. So one of the speakers has talked about innovation, efficiency, technology, and customer focused in private sector. They also come in handy in regards to complementing the public sector, that is decongesting the public sector. And in this case, we are seeing so many other private sectors coming up and also improving services and also expanding the number of services that a facility is giving. We've seen over time, most of the private facilities now offering TB services, offering HIV services, offering immunization services, something that was not there before. Also, with the SHA and SHIF, we've seen the emergence of the primary care networks, and these primary care networks cannot function without the private sector. We've seen private sector playing a key role in regards to being hubs, to being mini hubs, and also complementing the aspect of healthcare. And lastly, the other importance is in regards to the support on the optimizing of the channel. We've seen right now departments, the government departments, venturing into private sector, where key services have now been devolved to the private sector. For example, previously, family planning methods were just for health facilities, but right now, the government has ventured into the use of pharmacies to provide family planning services. So it is important to note the importance that the private sector has actually played in health. So to come into my question in regards to regulation and cultural mindsets and what needs to change urgently, one of the things that the private sector that needs to change in the private sector is the aspect of donor dependency and reliance. We've seen before partners calling private sector facilities and players for trainings where they even pay for their transport, they pay for their meals, they pay for their accommodation. And this was purely donor funded. And with the diminishing donor funds, we are seeing that changing, whereby the private sector now needs to come in and also cater for themselves. Recently, we've seen USAID withdrawal from funding health in Kenya. And one of the biggest affected department is now the DRMH, where family planning commodities are no longer being procured by the donors. So the private sector now needs to come in and see how they can complement these, and also to start procuring items for themselves. When called for trainings by partners, they should not ask the aspect of, are you paying for my transport? Are you paying for my accommodation? Because by the end of the day, we are impacting knowledge, we are providing certificates, which are also helping them in regards to regulation, and also when they are renewing their licenses. The other thing that also needs to change in the private sector is that in the recent past, private sector have been seeing themselves as competitors. When you have a facility A and a facility B just nearby, they look at themselves as competitors. And by the end of the day, they are serving the same patient. They are serving the same community. It is important that now the private sector change that and look at themselves as complementers. They look at themselves as partners, and also look at themselves as collaborators. This also needs to proceed to how the public sector regards the private sector, because in most cases, in most instances, we've been seeing the private sector and the public sector kind of they're not looking at each other on eye, simply because they're all suspicious of the other. So by the end of the day, we need to foster public-private collaboration and enhance complementation and collaboration within the partners. The other thing is that over the year, the processes in the private sector have always been exposed with a lot of bottlenecks. For example, if a facility needs to register for SHA or previously now the NHIF, there were so many bureaucratic processes that the private sector was subjected to. And with these regulations, it ended up having a lot of problematic aspect, whereby most of now the other private sector facilities had to even now start operating without the licenses. So we need to see how these can change so that the process in regards to regulation, the process in regards to empanelment, the process in regards to bringing on board more other insurance companies to play is actually smoothened, and we end up not having challenges like that. Dr. Eric talked about fragmentation in financing and the aspect of the need to harmonize funds. Because when we have a lot of fragmentation in regards to financing, then it also needs to be changed so that we end up having a clear-cut finance process, which will actually drive change. And lastly, when private sector generates a lot of data, because if there are 54% of the facilities in the country are from the private sector, it clearly means that they are generating a lot of data and a lot of indicators are being tracked. And you'll find that this data is not being used. So it is important right now that both at the private sector players, at the county level, at the sub-county level, and even at the national level, we see how we can tap into into the private sector data, especially generated from the health sector, to help inform changes, to help drive decision making, and by the end of the day, we are going to look to have good healthcare that is provided to the Kenyans that we are serving. Thank you, and back to you, Rahel.
Thank you, Robert. And your comment on over-dependency or over-reliance on donor-funded programs, I think it's high time we have this conversation, and probably it's coming in so late when the likes of USAID have, come out from the country and they're not supporting the way we thought they would support. And now a lot of providers across our there's a decry that how will we survive? But I believe the solutions are within ourselves, and it's high time we start being more action-led than, any other thing apart from being action-led. So thank you for sharing that. And just talking about quality, and Dr. Eric, allow me to ask this question. There was a comment on the chat about the quality of care bill, and about the aspect of quality of care. But I believe there's also an aspect of transformation within the system when we adopt such bills. And I know there's a lot of work that is still being done on it. But what will be your perspective around this bill and just improving quality of care generally across the system so that we can have the transformation that we need? And obviously this will get us closer to the objective that we are talking about today, which is sustainability.
Thank you, Rahel, for that. And I took a cursory glance at the quality of healthcare bill, and it did not meet my expectations largely because it just focused on regulatory issues. And we already have bills and laws and regulations already around regulation. And for the respective bodies, whether it's the lab, the pharmacy units, KMBDC, dental unit, we already have that. What I was hoping to see was a paradigm shift in terms of focusing more on, having a shift from infrastructure-led focus on quality to more on the actual delivery, care delivery. For example, I wanted to see more on how we are going to harmonize treatment protocols and establishing a mechanism and a way of ensuring that we have a central body that is tasked with ensuring that we have clinical protocols, we have clinical guidelines that sort of guide how care is given in the country. It's something as simple as hypertension. What is the first line? What is the second line? Third line? Complications, which drugs do we buy to handle certain complications? And then that is trained across board, because what that does is that it harmonizes the procurement, because you now know that drug X and Y is our first line, so this is what we need to procure. We already have data that is already telling us how many hypertensive cases we have, what are the drug consumption cycles. Commensurately, these are the tests that need to be done. So do we have the machines? Do we have the reagents? What partnerships can we draw from that? So that when we sit down and monitor outcomes, an outcome is not, a good outcome is not measured by the fact that you had 2 operating theaters, for example, for you to be a level 4, or you had a consultation room that was 6 by 5 or by whatever, because they're really not so important as much as the things like the actual care that is happening, so that we avoid fragmentation, as I said, in terms of how we manage patients. You realize that a patient managed for malaria in Kisumu will be managed, malaria management in Kisumu might be different from Mombasa, will be different in Garissa, yet this is the same patient. So I was expecting to see more focus on now the real healthcare delivery as a marker of quality, rather than regulatory issues where we have laws and many other documentations to that effect. So that's the part where I felt the bill fell short of. And I hope all is not lost. I think the only thing it said is that the cabinet secretary has the authority to develop the protocols and so on. But it just didn't focus so much on that, as much as it was loud on fines and, you'll be liable for these levies will be charged by these particular bodies. So it basically looks like another, almost like a revenue generation document. So there's a lot more that we were hoping to see, but I hope whoever who's in the decision-making spaces will take this and probably put it into consideration. Thank you.
Yeah, thank you for that. And I believe we also have a mandate, right? Eric, Dr. Eric, we have a mandate as the healthcare practitioners to actually put in our suggestions to such bills, because as I mentioned earlier, most of the time we become reactive, and we've seen just the way our systems work, not just the healthcare systems in Kenya. We become very reactive at the end when things are being implemented, and then we start asking, why were we not involved? So I believe we have a mandate, and Dr. Eric, you sitting at your position, I believe this is something that needs to, the conversations they need to continue, and they need to be more proactive rather than reactive.
Yeah. Very true.
Yeah. So as we come to an end, I want to ask all of us a question, and everyone who has joined, please, if you have a question, please put it on the chat so that it's not just a conversation amongst us. We can have your insights as well and questions, and please challenge us in some of the remarks that we are giving. So Gideon, over to you. Let me ask, in terms of transformation, right? And transformation is such a huge word. But in terms of transformation, from where you sit, you are in the technology space, right? But you have the understanding of the healthcare system and how the system works, both as an individual and also as a contributor or an enabler. So where do you believe we need to start? Do we start from policy reforms? Do we start from education? Do we start with innovation? Where do we need to start from where you sit?
That's quite an open question. I think all are important. There's never one that sort of like supersedes the other. Policy can sort of like go hand in hand with innovation. From my let me just give one example from my experience. I think from a technology standpoint, I'm sure also Jean and the rest of the team here, including Geoffrey, we have been waiting for sort of like a harmonized data dictionary for 10 years. But that has not hampered private sector to innovate or to sort of like go on with providing solutions that might not necessarily leverage that component that is very critical to some of the healthcare sort of like ambitions we have. I think everything needs to work. We have the privilege of working in several African countries, and I'll just leverage one good example I see in Ghana. In Kenya, unfortunately, we are trying to bring in policy and regulation in the tech space after sort of like we've gone through sort of like an innovative revolution. But in Ghana, they didn't have that. And what has happened is government, I think 5 years ago, just had some policies moved forward, and companies just adopted that quite easily. So we know that it's very possible. We know it's very achievable to sort of like have sort of like a harmonized ecosystem. Fragmentation is a big thing. One of the things we've tried even as UNIMED is to, like, let's just, we can't do it alone. Let's just collaborate with other private sector people, including people who might have been perceived as competitors. But I think at the end of the day, I've noticed that it's just always easier to come together and champion for the same things as one voice. So to answer your question in one simple statement, I think everything just needs to go at its own pace. Let everyone do their piece. There are people who are very good at advocacy. Let's just support them. The people who are good at innovation, let's support them. So it's everything at the same time, and there's always precedence to how things work. Once one project works at scale, I'm pretty sure the entire country will sort of like have focus on that. The same way Jambo Pay and fintech in Nairobi sort of like had a very good reputation in revolutionizing revenue collection in counties, for example. Yeah.
Yeah, I really love that. But just before I allow you to just take a breather, a follow-up question. I have not heard, where do we need to start? Are we starting from leadership? Are we starting from innovation, introducing innovation in a more robust way? Are we starting with sitting in roundtables to discuss the policies that are not necessarily working? And there's a comment even on the chat about advocacy and, do we need to push more? Do we need to have the right leaders in the spaces where we need to have our voices heard? Where do we need to start according to you? Just one word answer. Yeah, where do we need to start?
That's still me?
Yes, that's a follow-up question.
Yeah. No, it's okay. I'll just say what we're doing right now is good. To be honest, small groups tend to create momentum. You might meet people who you actually get to. Let's just I will say let's start with small groups. I think fragmentation has been a theme. It's also fragmentation in players in the healthcare industry. We have sort of like organized events at large scale, but I think just small groups. At Unimed, we are doing sundowners at least we try to do every quarter. We've not done that at least this year twice, which I think we've only done once. But I think just convening us, for example, here will create some momentum. And I think whether it's policy, whether it's I think interaction always fuels momentum. So for me, this is already good because I'll meet Robert today, I'll meet Geoffrey, and I'll meet other people. And then suddenly it's like, okay, next week, can we set up a meeting and actually do some action points? So I guess from the theme of this conversation is what do we do after meeting? So it's definitely making sure we also follow up and do those actions. But I would say meeting and interaction definitely is a good start, in my opinion. Thank you.
Thank you. Thank you. And Geoffrey, to you, the same question. For you, you sit, in front of these patients every other day. Okay, you're at the back end because you're in IT, but still, you understand what I mean. So you're at the forefront and you're facing the people who actually need the care, the people that we are supporting within the system. So where do you think the change needs to start happening? Where do we start the transformation? Yeah.
Rightly said, and I think the answer was hiding in your question. We need to start with the patient. So how do we have continuous patient monitoring? How do we continue ensuring that the patient health is guaranteed even outside our care facilities? How do we make sure that when they're visiting the pharmacies and they take a Panadol, that this information is visible to everybody and patients have the awareness that what they're doing outside there impacts the care we give them inside here. So it's government this, government that. But just yesterday I was sitting in with the team that is building the HIE, and you can hear me correctly? Yeah. So and one thing I like is about that whole journey is that the fact that we are now going to enable the patients with the information about their healthcare. So if you go to whichever facility you go to, whether it's a pharmacist, whether it's a hospital, you're armed with that information and you know what happened to you at each point, and you're able to audit that openly with everybody else. The other point is, I think we just need to continue, and don't mean to sound like a government pro-government kind of person, but I really like the new healthcare system whereby we have community healthcare workers This is about enabling the community healthcare workers, enabling the dispensaries, enabling the healthcare centers, because these are really the daily touch points of a lot of Kenyans who cannot afford coming to facilities like mine, maybe because of financial reason or just geographical limitation, and just enabling these teams with technology that will help them give the quality of care that they deserve at that level and at that capacity. I think those are the things that we should look at as low-hanging fruits that we can quickly enable, and you'll be surprised at how cost-effective enabling a community health worker is, and the impact that it will generate in terms of being able to look at the community nutritional requirements, looking at the community's healthcare requirements in terms of per age group. What are we looking at? If it's the babies, if it's the growing children, if it's the pre-adults, and also the old people and people who are working. If we are able to take care of these communities, by the time we are coming to talking about healthcare as we traditionally understand it, which is hospitals, we are now talking about treatment, but we have done a lot of preventive healthcare in the communities. And to me, that to me sounds like a much better plan as opposed to trying to cram every other service into every other facility that is available and to every square foot. So I think, first of all, having a very healthy community, having very good quality of life will impact a lot in the healthcare agenda.
Thank you, Robert. And I love, sorry, why am I saying Robert? Geoffrey, thank you. Thank you for that. And I'm glad you have shared that, because one of the things that I'm really grappling with, even as an enabler in this ecosystem, is why we focus so much with creating solutions in Nairobi, in urban areas. Like, we are just so focused. We're creating solutions here. We are catering for the quote unquote 2%, and we don't go out to cater for the 98% who need that support even more than the 2%, in my opinion. So thanks for sharing that. And Nyakio, to your comment, the comment that I can see on the chat about doing hard advocacy, right? Where do we think the problem is? And I think I alluded to that earlier. Is it the leadership? Is it any other thing, right? And where do we need to start, or rather, what needs to change in the system so that we don't feel like it's hard advocacy? Because healthcare is a critical sector, right? We are not, or rather, everyone who's putting their ideas to the forefront or contributing to such builds, it's not about anything else apart from what we want to achieve in terms of even transformation, because that's what we're talking about today. So is it a question of leadership, or is it something else? And as you answer that, and feel free to contribute on the chat or even unmute yourself. Robert, to you, the same question. You interact a lot with these healthcare providers on a day-to-day basis. You have been the forefront in terms of pushing the agendas for donors, for a good reason, obviously, because at that particular point, there was transformation that was needed. So where do we need to start? Is it from a policy standpoint? Is it from leadership? I talk about leadership a lot because I believe leadership is the answer to a lot of these things. So is it policy? Is it leadership? Is it innovation? Or a combination of all these things?
Thank you so much, Rahel. I think from me and from where I sit, I'm looking at it differently. One, it is said that Kenya is one of the countries that has got one of the best policies, guidelines, protocols, but by the end of the day, we are not using any of those policies. We've seen in the previous past policies being formulated here in the country by different government departments. But by the end of the day, those policies are just put in shelves to gather dust, and they are very well implemented in other countries. We've seen there was a time there was a policy that had been adopted in Rwanda, and it was 100% photocopy of what had been developed in the country here in Kenya. So for me, I will not go for starting from the policy level or from the policy reforms. I will start by understanding where the need is. And understanding where the need is, to me, I'll front education. We need to start with education. We need to start with a change in educating our patients, educating our healthcare workers. And by the end of the day, as we implement that, we end up removing the bottlenecks that are there that are actually hindering the accessibility of better health and well-being. So, and that will also translate to leadership, because once we bring in education, we get to understand the need, it will definitely go hand in hand with the leadership. And once we start there, we are going to bring a lot of change in the provision of health services, especially in the private sector.
Thank you. And I like the perspective you're sharing around education, because I believe there's a lot of gaps, especially with digital literacy and what we can do in the system in terms of building that education piece. So thank you for sharing that. Dr. Eric, lastly to you, where do you believe we need to start? Policy or innovation or leadership, or all the above?
Oh, well, I think we need to start anywhere, because any movement is better than no movement. And there is a lot at policy level, at leadership level, that needs to be worked on. But all these things are not mutually exclusive. So I think for me, looking at all these pertinent issues that are there, policy would be a good point to start, because it sort of gives a shape to the vision. It gives you an idea what are then we working on. Then everything else is building up to that. However, the problem with starting at policy is that these things take time, and a lot is lost in the process. Providers are hungry. Other stakeholders are also suffering. So it should be that we have willingness from both the public and the private sector side to have these conversations ongoing, have an open forum for conversations. I remember the immediate former PS for health, Kimutai, especially during the transition period. He was very vocal in terms of ensuring that we have a private public sector engagement coming together. We used to meet at the SHA offices, I remember very well. We'd look at the teething problems, we'd provide solutions, and move on. And I think that on its own helped us avert quite a lot of issues that we would have faced with the rollout. So if that can be deployed, then conversations become easier. Then we don't seem to look like we are in competition with the government, but just complementing whatever the government is doing. Thank you.
Thank you, Dr. Eric. Yes, thank you so much. And I mean, I just appreciate all the sentiments that have been shared. And for me, if I can summarize it all, there's an element of action, and action starts with us. And I know we've talked about this so many times, and sometimes you feel like the system is resigned to, whatever happens. So whatever comes, we'll take it. But I believe with this initiative, we will hopefully start creating those building blocks that will start changing some of these things that we've talked about today, and obviously with your support. So I really want to thank Dr. Eric with your leadership at CAF, Sylvia, who was here before, at PSK, Robert, Gideon, Geoffrey, Jean, all of you are leaders in your own right. And with these conversations that we have had, I hope, and it's not even hope, I just want us to start moving with action, because we've talked for a very long time. We've had these conversations for a long time. And I'm not saying conversations need to end. Beyond this conversation, what is the next action? And this initiative is that action. So the link that has been shared on the chat is just for us to understand you as a healthcare provider much better, so that we can offer the support. And I believe with the partnership with CAF, with PSK, we can start this journey. And this is the start. This conversation is the start of this journey. So thank you everyone for being a part of this. And finally, as we end, I would love to request the panelists to just share their last remarks, and we will close it off. So Dr. Eric, allow me to start with you, and then we can go to Geoffrey, Gideon, and then Robert can close us off. Thank you.
All right. Thank you so much, Rael, for this opportunity, and it's been great learning from the panelists as well, the different facets of healthcare. And I do hope that in the next coming days, because it's usually very easy to have the meetings, but then now putting the work and the energy and the effort into the resolutions is usually the difference between success and failure. So I'm seeing an opportunity where this can move from conversations to actions. We as CAF are here to support the initiatives that propel the common good of the sector, and also the members of the public that we serve, the Kenyans that we serve as well. And this is one of those particular initiatives. So I also believe the government has no solutions to all the problems that are there. We may have some, but not all the solutions. So a collaborative effort between the private sector and the public sector helps move or push the needle forward. So as CAF, we can we state our unequivocal support. We're here to help us transition into the next steps. So you can always count on us. Thank you.
Thank you. Geoffrey, over to you. Geoffrey, can you hear me? Okay, I think Geoffrey is having issues.
I think for me,
okay.
No problem. I'm now audible. Yeah. So for my side is as just to keep with the topic that we now need to move a bit more carefully and a bit more can I call it with more conviction into helping our own organizations, our own institutions in making sure that we are efficient, making sure that we're doing the right thing by the patient. And in technology, we talk about people, process, and then technology. So whichever innovations that we might want to put in, we might want to think about how we helping the people, how we helping the process. And this will help us find which is the right technology that we want to put in very quickly, which one is going to give us more results. And as a rule of thumb, we need to always make sure that quality is our guiding KPI for all these things. Yeah, thank you.
Thank you so much. Gideon?
Yeah, I'll finish by saying I think it's very apparent that regardless of how we talk, it's always the patient who's always the person we're talking about. And like we said earlier, I think the needs are echoed through either institutions, government policy, and the rest. So I'll be very I'll emphasize collaboration very much. Any movement towards collaborating, and that could be Public-private, I think what I've been witnessing in my own sphere of influence is a lot of private-private. So basically private companies just coming together and trying to see, okay, what can we do together? I do know that these conversations do occur apart from webinars. It occurs in smaller groups, and I've seen the power of that. And I think that's definitely an easy blind spot, because sometimes when you just have the conversations, definitely it sparks action. Let's not get tired. I do know that there's some apathy that's created when you have so much conversation. There's normally a term we use in our company, which is like conference apathy. You've gone for so many conferences, you don't feel like going for more conferences. But if we can just decide at the right level where we're not apathetic towards government, you're not apathetic towards collaboration, you're not apathetic towards conversation. I believe in those circles, there's always like some sparks here and there that definitely foster movement. So just to underline, collaboration for me will be a big parting shot for everyone. Let's not get tired. Asante.
Thank you. Robert, please close us off. Thank you.
Thank you so much, Rahel, and everyone who has had his or her remarks. Mine is to finish it this way. They always say that a journey of 1,000 miles starts with a single step. And I think this was one of the forums that we have started. This was our first step. And going forward, we need to now get to the next step and see what will be the next agenda in fostering and facilitating the private sector aspect, so that we have a strengthened private sector, private health sector players. Two, as one of the speakers has just said about fostering partnership and collaboration, it is very key, because we come from different backgrounds, different partners, different organizations with different strengths. So I think we need to leverage on that and see how we can move together. Lastly, private sector plays a key role in health sector. And in this, we need to see that we have brought them on board. At least we have facilitated and removed the bottlenecks that are there, that are hindering their success. And through this, we need to push for private sector representation in different forums. When Yunik Global, maybe you are in a meeting that has been planned by the national government or even by the county, it is important to push for private sector representation, for private sector involvement, because sometimes we see counties, we see governments planning, but by the end of the day, there is no private sector involvement. Just as the youth say, nothing for us without us. So let's also push that agenda, that nothing for private sector without the involvement of the private sector. Thank you so much, and back to you, Rahel.
Thank you, Robert. And I will not add anything more. You have summarized it very, very well, all of you. Thank you so much. And from me, it's just a thank you to Kenya Association of Private Hospitals, the chairperson, Dr. Eric. Thank you to Jean Kyula, who's the vice chair of the Digital Health Committee of Kenya Healthcare Federation. Sylvia Wamuhu, director, private engagement. Robert Nyaro from PSK, thank you so much for the mobilization. Geoffrey Gitagia, thank you so much for your participation and contribution. And Gideon Chalo, thank you so much. And I look forward to having you being involved in this journey. And I know there's so much we can do together. So thank you. And thank you to all of you who have joined. We will not have done this without you. So thank you. And the fact that you have stayed on till now means that this conversation was definitely for you. And I pray that it has impacted you in one way or another. And as we start this journey, please join us. And we believe that at the end, we will see the transformation that we are looking for. So thank you so much. Have a good day ahead and see you in the next session.